Okay, these are the equipments what we have to measure the activity before injecting to the patient.
So
okay,
this looks like some chasm.
yeah. In our education, in our post-graduation program, one is about the reporting. So more than reporting constitutes around 30%.
Okay.
Another 70% will be starting from what radio tracer to use, how we maintain the radioactivity. It should be within the limit.
Got it.
That gallium I will replace with the lutetium, actinium. These are therapy molecules. They are what I told as we discussed. It's like a alpha emitter or beta emitter. Progressing all lesions like this. She was not able to lift her hand. Just we gave the lutetium dotatate therapy. It is, I think, is second or third in the world. We have done this therapy.
Super.
And within 1 week, entire lesion has come down. Everything has come down. She is able to do every work.
And in this video, what we are going to cover is the scope of nuclear medicine. So today we have Dr. Pratap with us, who is a nuclear medicine specialist in Astra Whitefield Hospital. So their department is nuclear medicine and theranostics. So today we are going to cover how actually they treat the patients and what is the flow of the patient and also the equipments they're going to use. And the reason why we're doing in detail is that many doctors, including me, we don't know what actually a nuclear medicine specialist does. So we want all the doctors who are following this video to see how Dr. Pratap works and what kind of equipment he uses and what exactly they treat or exactly they diagnose is what we are going to learn in this particular video. Welcome to the channel, Dr. Pratap.
Hi Dr. Dheeraj. Yeah. Please come in.
Yeah.
This is the Department of Nuclear Medicine, PET CT and gamma camera what we have, and this is when you come inside our department, we have two major equipments in our department. One is called the gamma camera and one is the PET CT, which is over here. This is the PET CT. Okay. We do some functional imaging with the gamma camera and the anatomical and the functional both imaging with the PET CT scanner. Just we'll have a look of the gamma camera and then we'll proceed.
So is it safe to go inside and...
Yeah, it is absolutely safe.
So this,
because
you gave me this one. So
we are given you the TLD just to monitor how much you might get exposed while you are here. Because entire this area, patient will be injected with the radio tracer and they will be emitting radiation. One or the other patients will be there. Therefore, we will be monitoring what are the radiation we get. This is the TLD, we monitor it with this for us, and this is the temporary TLD, which will be given for whoever the visitors is.
So here we'll finish up the radiation hazard part for somebody who wants to join. What is the hazard of radiation?
Practically, there is a certain limits which are set for the workers, radiation workers, which will be, most of them will be within the limits. Therefore, practically nothing to worry. We can work in this department, not an issue.
Got it.
And most of the time, what we analyze is we are not much exposed to the nuclear medicine department in our undergraduate days. Therefore, we'll go from little basic wise, then we'll have a look. This is what we call as a gamma camera. This is what gamma camera is, a dual head gamma camera. We have two heads. What we do, we have different radio tracers. Different radio tracers, different for gamma camera. The radio tracer, what I use for PET scan is different. What I use for therapy is different. There is three different radio tracers. Like one emits gamma rays, one emits alpha rays, one emits beta rays. Alpha and beta rays are very powerful rays, but they travel only less, like 1 or 2 cell range. Therefore, that we use for therapy. Whereas the one which emits gamma rays, they travel more, but their energy is less. Therefore, that we encache it for scanning.
So basically, you diagnose conditions and you treat also.
We treat also. Most of the time, almost as of now, like 80% is diagnosis, 20% is therapy. In diagnosis, what we do certain scans in this gamma camera, certain in PET scan. What are the scans we do in gamma camera is like every organ we can do the functional scans. What functional scans? Basically, many will be knowing DTPA scan for kidney. We might have 2 kidneys, out of which only one might be functioning. That to know whether left kidney is functioning, right kidney is functioning, how much my left kidney is functioning, all these things we will give one tracer. That is called technetium DTPA. We take around 20 minutes image. In that 20 minutes, after that we have a software which processes and tells how is his left kidney, how is his right kidney, whether left kidney is obstructed, whether the right kidney is abstracted, whichever the one, and which then after the procedure, after the surgery, if any obstruction is done, to see how well the surgery has gone down, how the kidney has improved after the surgery. Basically, in ultrasound CT, what we see is the anatomical imaging. We see how well it is, how big it is, or whatever that is. Here we see the functional things. Whether it is functioning normally, functional obstruction is there or not, like that. Not only just the kidney scan, we do scan even from your
brain
CNS, brain also. Brain, during the epilepsy or the seizure, we give some tracer that goes and binds there. We can know exactly where the foci of seizure is coming.
Oh, that is very important. For epilepsy surgery, we can remove that part.
We can remove that part, exactly. And then
so what tracer is given? Technician?
Technetium labeled ECG. Whatever we do with the gamma camera is most of the time is a technetium labeled scan. Or iodine scan, because that energy suits it. That's all.
So these radioisotopes usually come from under the earth or something?
Yeah, these radioisotopes we use under the nuclear medicine, because we are nuclear medicine people are the ones who are recognized by AERB to use this. AERB is an Atomic Energy Regulatory Board in India, which regulates all the nuclear medicine or the whatever the nuclear things involved. And the nuclear medicine, we guys get one number called RP number, the radiation professional number, out of which we are licensed to use that. We are licensed to use this whatever the radio tracers. Then we get it. Some are imported, some we get it indigenously. Some we get it from Baba Atomic Research Center. They produce it. They have the nuclear reactors. From there they produce and we get it. And this they decay with time. For example, there is some generator. I will show you inside. There is a molecule. We can see over there. Then we can go ahead. Please come. This is our extension of the SPECT area. This is low dose iodine room, where we give you low dose iodine therapy. Whereas our high dose iodine therapy room, we have our 6-bedded room that side, which is on the other side, but we have a therapy aspect also.
So basically, I'm very ignorant about all this. So low dose and high dose, for what diseases?
Low dose, high dose, we for Graves and all we give low dose. For thyroid cancer and all, if it is little high risk, we give for the high dose. If it is not, if it is in low or moderate risk, intermediate risk, we go for the low dose itself. Low dose is a OPD based procedure, iodine therapy. If it is high dose, we admit. We do admit in the high dose therapy ward and we give. And there is something called lutetium therapies, actinium therapies that we give over here only. That is, we do it in the low dose room. Then if you come inside, we have SPECT dose admin area. What is the SPECT dose admin area means? This is the place where prepare the dose for the gamma camera. Then we inject the patient here. After that, the scan will be done over there. You can see there, this is the technetium generator what we have. Here we can elute it. It is just like a cow. Where from the cow, how we get the milk, we can get the technetium, and that will come around 1 week to 15 days based on how we use it. And after that, after the technetium, we will label it with whatever the agent we want. For example, if I want to do renal scan, I label with the DTPA. If I want to do the lung scan, I label with MA. If I want to do brain scan, I label with ECG.
So that labeling,
we call, we have our team of radiochemists. And also we also do it. We are during our training, apart from reporting, whatever it is, this is one part we learn. That is the radiochemistry aspect. 3 part we learn in our education, in our post-graduation program. One is about the reporting. So more than reporting constitutes around 30%. Another 70% will be starting from what radio tracer to use, how we maintain the radioactivity. It should be within the limit, and how to prepare that activity, and about the machines. It is like we had separate machine like gamma camera and PET scanner. We read about all these things, all the physics involved with that.
So here radiochemist you told, no? So they are technicians separate.
Yeah, they are technicians. They are nuclear medicine technicians basically. There is a 4-year course for them. BSc nuclear medicine and MSc. It is a separate. They will be helping hands for our department. Nuclear medicine department is
so even they have good demand, I think.
Even that course has good demand is there.
Got it. Some BSc people also are following us.
It's a good branch.
After 12th they can enter maybe.
After 12th science, they require physics, chemistry and mathematics something. And they can go into BSc nuclear medicine. It will be a 3+1 year course. Then
so that which is once he goes inside the gamma camera, then you inject the material into the image before.
There is a protocol for how we do the scan. Some scans are dynamic, some scan are not dynamic. For dynamic scans, in the sense, what I mean, under the camera I inject and I see how it goes for imaging. Like 20 minutes I see the renal DTP, how it goes inside, how it gets excrete, all these things. For thyroid scan, I just inject and I leave for 20 minutes and then I see the uptake later on.
Oh, you need some time for
some
that.
time to go there and localize there. Whichever material which is not localized gets excreted through urine. And the amount we use is very much minimal. Nothing to get feared about. Basically, as per the recent American Radiological or Nuclear Medicine Association guidelines, these scans are very much safe and there is no need to not to do even in pregnancy also. Whenever we do the PET scan also, the more radiation component is because of the CT what we have along with the PET scan, not the, more than the
not because
radio
of
tracer.
Radio tracer.
Not with the radio tracer.
Okay. Then we'll see the next area. Gamma. So what will be the cost of this equipment roughly?
The cost will be very high.
Very expensive.
Cost will be very expensive. These equipments are basically costly. This is the PET scanner what we have.
Okay. It's looking like an MRI only.
Yeah, it's looking like an MRI. But if you come in a little observe here, this is the CT part.
Okay.
And if you go below, behind, that is the PET part. Okay, initially CT, behind it is a PET. It's like CT will be taken first, then the PET acquisition happen, and combined we get a PET CT image. And PET CT, the beautiness of it is a colorful image. It will highlight. Even if I want to miss it out, the color will drag me and show me I am here. You look at it.
So got it. PET scan is mainly helpful in identifying metastasis.
Basically, the indication of PET scan is wide. Starting from neurology to oncology, we can do specific brain PET or cardiac PET based on the indication. And most of the time, 80% it is indicated for oncology purpose to stage, what stage it is. Initially, it was like only FDG PET scan. We might have heard PET scan came around 15 years ago. It was only FDG. But now in the Center of Excellences, all these places, what we use is not FDG. Our 80% of the load is not FDG. We are 80% thrown away the FDG and we use different tracer. Why the different tracer is, the quality of image is better with the new tracers. The imaging is better, the better staging happens, and more than that, it is patient friendly. Why patient friendly? FDG PET scan we should do only in the morning time. Early morning, we need 8 hours fasting and blood sugar should be controlled. We know India is diabetic capital. We have so many patients who are coming morning, going away, not getting the scan done because of sugar issues. But all these are not required because of the new tracers called FAPI PET scan. What we do is the FAPI PET scan over here. The advantage of FAPI is like it has become like a CT scan. Even now you saw we are doing the PET scan. It is like even in 5 o'clock in the evening, 8 o'clock in the evening, we do the PET scan. The patient comes to walk in, we prepare in-house, we have a generator. Just like the technician generator we saw, we have a gallium generator. That gallium generator comes for almost a year. We import that from Eastern countries. Then we label it in-house, we make a product, we make a gallium FAPI or gallium PSMA, gallium DOTA. Then we inject to the patient, that will give the images, colorful images where the disease is. It is like becoming like a one molecule is not a fit all. Before it was like only FDG. Now it is not like that. It is based on the tumor. For example, if it is a prostate cancer, we do PSMA PET scan. What does that mean? Means it is PSMA, prostate specific membrane antigen PET scan. It will detect only the prostate cancers which are gone outside, and we get images and we know these are the places where the disease is. And the NET, neuroendocrine tumor, we do DOTA PET scan. Our FAPI PET scan in almost 80% of the tumors we can do FAPI. FAPI has almost replaced FDG in our center now. We are doing FAPI PET scan. And the next thing is why these PET scans helps us. It is just like seeing the image and also looking at the image within how it is and seeing their receptors. It is like a IHC, we see only that focal area where they are biopsy, but in the PET scan we can see the entire body image where how the receptors, everything is expressed. That has got a therapy implication. What I do in nuclear medicine, we have agents, radioactive material and the tracers which we attach to them, then we inject, it will go to the tumor and it will highlight.
Yeah.
Okay, usually in FDG goes to highly metabolically active cells, then it will be detected. But whereas PSMA, it goes to prostate specific cells. If I can see the metastasis in all the areas, prostate specific cells, in diagnosis I would have used gallium, which is low energy molecule, because that is a PET tracer. That gallium I will replace with the lutetium, actinium. These are therapy molecules. They are what I told as we discussed. It's like a alpha emitter or beta emitter. Alpha emitter and beta emitter, they travel very less.
Okay.
And this PSMA, it will help to go and localize there, and it will bombard, it will blast it. It is like what I say, it is like a GPS tracked missile launching.
So it will not, basically what I understood is without damaging other structures,
Exactly.
directly go to point,
Directly
deliver
the
medicine.
radiation, deliver the
radiation.
radiation basically, and it will cause single stranded or double stranded breaks of the DNA, and a cell, whichever the cancer cell which is expressing it, it will die. Therefore, we don't see any side effects out of
So
it.
this is the future of...
This is the future of, actually this is
So
the
all
future
the tumors can be dealt in this way maybe?
As of now, 2 tumors, it has been FDA approved for prostate cancer, metastatic prostate cancer. Now, initially when it was discovered or invented or whatever it was the last line of therapy.
Okay.
After chemotherapy, everything like that. Now it has come up there for the front line because it has succeeded all the studies results, and it has come up the front. Why? Because it has no side effects. What we see many times, what we used to do, we used to treat the patients after chemotherapy or anything. Then later on we used to do. Then after progression after chemotherapy, patient used to take this therapy and they used to respond very well. For example, actinium, PSMA and all, we have seen PSA from 2000 coming to 0.1.
Okay.
That much dramatic response with prostate cancer. And same thing with neuroendocrine.
So at present
prostate and neuroendocrine are there. And the next thing is like not everywhere it is happening.
Not brain, I think.
Brain definitely, because the blood crossing the blood-brain barrier is a difficult thing. But we are doing for the brain. There is a substance P PET scan. Substance P PET scan, which is actually crossing. And what the radiation what we are able to deliver out of it is like 100 gray. 100 gray. How we are doing? Opening the reservoir, putting there directly, we are injecting directly with the help of neurosurgeons. We are able to.
You can put Omaya reservoirs.
Omaya reservoir, you can give over there. That area, that studies are going on. It's not yet.
So, but what I'm understanding is, it is still in the initial phases.
Correct.
Is what?
It is still in the initial phases.
It's still lot
of things to happen. And there, what I told us, like DOTA and PSMA, almost most of the people will be doing. And there is something called FAPI. What does FAPI means? It is a fibroblast activating protein inhibitor. It's almost like a pan tumor marker. It is almost present in 80% of the tumors. Like all solid malignancy, whichever the tumors which are aggressive, this has a FAPI coat will be there. For example, any cancer, it should grow in the body. Cancer is nothing but our own.
Thoracic tumor is there.
Thoracic tumor is there. That has
a FAPI layer.
Exactly, definitely. It is like how the basic how the cancer cells survive. Cancer is nothing but our own cells which are mutated, which are growing, which every day it happens in everybody's body. It will be killed by natural immunity. But whenever they start growing, they need some protection, or else my immunity will kill it. That is how the cancer cells are produced. They have the good fibroblast, that we call it as a tumor microenvironment. Whenever we do the FDG PET scan, we see the cancer cells. Whenever we do the FAPI PET scan and all, we see the tumor microenvironment. Now we have done the head-to-head studies, many meta-analysis, and now we have seen that the FAPI is more than FDG. That means the tumor microenvironment is more in the tumors than the actual cancer cells in most of the tumors. Therefore, what we are doing, the same lutetium we are doing with the fibroblast, and we are injecting to the patient. It is going there and it is breaking up all the microenvironment. Then the patients who are not responding to chemotherapy or immunotherapy, because these are like a protective coating, like a king having a Z plus security. That Z plus security we are breaking up and without causing any side effects. Then whichever chemotherapy which is not working,
it will act better.
Yeah, it will act better. It will act better. It will respond better.
FAPI will act for most of the tumors.
Most of the tumors.
So this might become the initial therapy for most of the
tumors with that line. Now, as we have done almost like 100 patients, we have done with the FAPI therapy. Our results are really beautiful, and the patients have survived 4 times than what is expected.
Great, super. So the tumor shrinkage also.
The tumor shrinkage has happened, and recently tumor will open up. The therapy which is not working, we have seen patient who is not responding on chemotherapy, they are responding to half the dose of that which was given prior, because it will break open everything, it will act very, very nasty, all these things. So for example, one patient we were expecting 4 months survival, he survived 1.5 years. With this therapy without side effect. That is all the good thing with the FAPI therapy. But
so radiation oncology will have side effects because it will affect the.
Let us discuss between what is nuclear medicine. Actually, with 3 branches we always get confused and overlapped. One is like radiology, nuclear medicine, and radiation oncology. This all 3 in India is like a specialty after MBBS, like a 3 years course, separate specialty. They have got separate roles. In radiology, we have ultrasound, CT, MRI, like that. In nuclear medicine, we have PET CT and gamma camera. And in radiation oncology, they have machines to deliver the radiation. Radiology is purely diagnostic branch, apart from intervention radiology. In radiation oncology, they have machines to deliver the radiation. For example, see a breast patient is there, we operated breast, everything is removed. Outside machine will give the radiation. Whereas nuclear medicine has dual component. One is the diagnostic and therapy. What diagnostic, we do the PET scan regularly, all these things. It is similar to radiology, but we use the radio tracer. Here in nuclear medicine, we use something called liquid radioactive materials that we use to the patient, that we inject. We inject to the patient and do the scan. Iodine we give orally, but all other things we most of the time we inject. Therefore, it is like we treat similar to radiation oncology, but how we treat, it is not through machine, it is through using the liquid radioactive material that we inject to the patient. We diagnose similar to radiology using the PET scanners. For example, now we are doing the dotatate therapy, all these things. Recently, 3-4 days back, as I was showing you that image, you responded very well. That case, it was a case of Merkel cell carcinoma. Progressed. It was recurred after the surgery. It is aggressive tumor. Everybody knows it, and it was progressing on chemotherapy. After first line immunotherapy, nivolumab, then pembrolizumab. It was progressing all lesions like this. She was not able to lift her hand. Just we gave the lutetium dotatate therapy. It is, I think, is 2nd or 3rd in the world. We have done this therapy, and within 1 week, entire lesion has come down. Everything has come down. She is able to do every work. You can. That is the response we are getting. What I mean to say is, the therapy options are rising up.
Just started now.
Started up. Yeah, it is very. Therapy options are very good. The patients are responding very good, and it is not. It is like we can't do this therapy everywhere. Okay. This is one fact, because we are in the center of excellence basically. Therefore, we are able to do this.
So this kind of centers, how many will be there?
This, for example, nuclear medicine center in India, 350, around 350-400 centers we have. In nuclear medicine center, if you consider, we can divide grossly as diagnostic centers, government setups with teaching institutions, and private setup with minimal setup, private institution with high-end setups. Like this high-end setup, we might get on 3-4 centers. Who does everything. It is not just the machine. We should have the access to good radio tracer. For example, what we do here is we are around 15 different radio tracers. 15 different PET scan we do. For brain, we do 3-4 different.
So to get those 15 stuff.
Get that. That is where everything matters. Everything matters in the sense we should have huge investment is huge, and there should be institute with support. We are the center of excellence, they support here, we do it, not a problem. Then there should be good caseload covering the entire spectra. Like Merkel cell, we were able to do it because this center of excellence, we get all patients here. If it is not, it will be difficult. Then second thing, we have teaching institute where there will be everything, but this is also little costlier department, because whatever the molecule we use are costly. Therapy, everything is good, but it is very costly. Most of the patients, what we see in government setup are practical reasons, they can't afford it. And even government can't support all these things because it's too costly. Then therefore all this
cost might come down. I think.
Cost might come down, but as of now, it is very costly, because cost might come down. Even if it is come down, like the amount what it comes down is not drastically too much. We can't expect. Why? Because these are all produced from the rare earth metals. It is difficult to get also. There are something actinium what we have. actinium is very much powerful,
Okay.
but getting the actinium is very tough. Even if I pay, I can't get it now. It is that much it's a scenario. But in the long run, it will come up, come down. And second thing, diagnostic center I want to work. Diagnostic centers, number of diagnoses
Only
will
PET
be
scan will be
only PET scan. Most of the places they do have the only PET scan, and number of scans they do will be more. For example, compared to the institute, number of scans what they do in the diagnostic centers will be more. But practically, whenever we tell about the students or anything, 3 years after we finish the course, usually we getting the course is based on what all the things. After 3 years, ideally, my personal experience, 3 years is not sufficient. Because 1 year will go for thesis or exams.
1 year adjustment.
1 year, this is physics, chemistry. What is this physics, chemistry? Adjustment. In 1 year, just reporting. Therefore, it is a wide branch. Any person who is willing to take the branch or anything, just after the completion of the course, they will have definitely option. Just like radiology, initial options are very good. Later on, it might not peak that much. It stagnates like radiology as of then. But still, my suggestion will be like they should go into the center of excellences, specifically in good corporates, where people also can afford, and many caseload is also there. Then they should work like 2-3 years.
Experience.
2-3 years experience. Then train the hand in hand. Then go out with the. They can do still more better than what they just go out with the 3 years.
So you are seeing more centers like this coming up in future?
Yeah, definitely. Centers will be coming up, but this full setup, not everyone can afford. Even we have Astra has 3 centers in Bangalore. In entire India, this is the center where we have put this much of investment. It cannot be practical.
Because 3 centers would be feeding here.
Yeah, exactly. It cannot be. Only Whitefield we are having because it is a cost involved. Cost involvement is much more there. But definitely centers will be coming, and most of the time this will be in the metropolitan cities. Tier 2, Tier 3 cities, Tier 2 it is coming up. Tier 3 as of now no. As of now no. Future we don't know. We don't know about the future. But Tier 2 yes, some setups are coming.
Till PET scan they can come.
Yeah, till PET scan they can come. Some of the other things will usually happen in the IR centers.
Understand. It's basically for metros.
Usually basically for metros.
For metros. You want to settle. So basically, so now by 2 to 3,000, lakhs of people write NEET PG. No?
Correct.
Getting less than 10,000 is very tough now. By 2 to 3,000, nuclear medicine is over.
Oh, is it?
Yeah. It is like before, see, you might get general medicine, you might get, even I think ortho, radiology and all that. Nuclear medicine is over by 2 to 3,000.
Okay,
so why is such demand created?
No. One thing I tell you, because number of seats are very less. I think around 30-40 maybe.
Very less.
Might be 30-40.
Other specialties, thousands of seats are there.
Thousands of seats are there. Mostly now I think
Which is best college?
For this one, there are actually we can't tell which is best here because everything is equal. Whichever the centers who are training are almost same, plus or minus 5%. The advantage in we have both government and private setups. Few centers, government and private. Government we have more load. We can't expect that tracer activity in government. Whereas private, even the load will be little okay. But we will have more access to the newer technology. Therefore, it should be combination of both for both. What I mean to say is, if any student is trained in a government institution, better he will come out and work 1 or 2 years in a private center. Therefore, we will have a mixture of both. If somebody is working in a private setup, if he goes for government, you will get still more volume.
So government 2-3 centers, if you have to tell which are better.
Tata Memorial Hospital is there, Mumbai. It has a nuclear medicine course. Radiation medicine center, it's even in Mumbai. It's a government college. Even SGPGL Lucknow is there. It comes under NEET. It's good. Like this, the centers are good.
DNB also is there.
Yeah, DNB is equally good. Equally good. There are many institutions in DNB. They are equally good. But only thing is, there should be. What I mean to say is, whichever the college they take, they get the equal exposure, either in government or private.
Got it. Plus or minus 5%, they get good experience. After that, where they continue their experience?
Where they continue, too much we can't expect. Why? Because these are all produced from the rare earth metals. It is difficult to get also. There are something actinium what we have, actinium is very much powerful, but getting the actinium is very tough. Even if I pay, I can't get it now. It is that much it's a scenario. But in the long run, it will come up, come down. And second thing, diagnostic center I want to work. Diagnostic centers, number of diagnoses
only PET scan will be there.
Only PET scan. Most of the places they do have the only PET scan, and number of scans they do will be more. For example, compared to the institute, number of scans what they do in the diagnostic centers will be more. But practically, whenever we tell about the students or anything, 3 years after we finish the course, usually we getting the course is based on what all the things. After 3 years, ideally, my personal experience, 3 years is not sufficient, because 1 year will go for thesis or exams.
1 year adjustment.
1 year, this is physics, chemistry. What is this physics, chemistry? Adjustment in 1 year, just reporting. Therefore, it is a wide branch. Any person who is willing to take the branch or anything, just after the completion of the course, they will have definitely option. Just like radiology, initial options are very good. Later on, it might not peak that much. It stagnates like radiology as of then. But still, my suggestion will be like they should go into the center of excellences, specifically in good corporates, where people also can afford, and many caseload is also there. Then they should work like 2-3 years
experience.
2-3 years experience. Then train the hand in hand. Then go out with the. They can do still more better than what they just go out with the 3 years.
So you are seeing more centers like this coming up in future?
Yeah, definitely. Centers will be coming up, but this full setup, not everyone can afford. Even we have Astra has 3 centers in Bangalore. In entire India, this is the center where we have put this much of investment. It cannot be practical.
Because 3 centers would be feeding here.
Yeah, so exactly. It cannot be. Only Whitefield we are having, because it is a cost involved. Cost involvement is much more there. But definitely centers will be coming, and most of the time this will be in the metropolitan cities. Tier 2, Tier 3 cities, Tier 2 it is coming up. Tier 3 as of now, no. As of now, no. Future, we don't know. We don't know about the future. But Tier 2, yes, some setups are coming.
Till PET scan they can come.
Yeah, till PET scan they can come. Some of the other things will usually happen in the higher centers.
Understand. It's basically for metros.
Usually, basically for metros.
For metros. You want to settle. So basically, so now by 2,000 to 3,000, lakhs of people need PG.
Correct.
Getting less than 10,000 is very tough now. By 2,000 to 3,000, nuclear medicine is over.
Oh, is it?
Yeah. It is like before. See, you might get general medicine. You might get even I think ortho, radiology and all that. Nuclear medicine is over by 2,000 to 3,000.
Okay.
So why is such demand created?
No. One thing I tell you, because number of seats are very less. I think around 30-40 maybe.
Very less.
Might be 30,
specialties, thousands of seats.
Seats are there. Mostly now I think
which is best to call it.
For this one, there are actually, we can't tell which is best here, because everything is equal. Whichever the centers who are training are almost same, plus or minus 5%. The advantage in we have both government and private setups. Few centers, government and private. Government we have more load. We can't expect that tracer activity in government. Whereas private, even the load will be little okay, but we will have more access to the newer technology. Therefore, it should be combination of both for both. What I mean to say is, if any student is trained in a government institution, better he will come out and work 1 or 2 years in a private center. Therefore, we will have a mixture of both. If somebody is working in a private setup, if he goes for government, he will get still more volume.
So government 2-3 centers, if you have to tell which are better.
Yeah, Tata Memorial Hospital is there, Mumbai. It has a nuclear medicine course. Radiation Medicine Center, it's even in Mumbai. It's a government college. Even SGPGL Lucknow is there. It comes under NIP. It's good. Like this, the centers are good.
DNB also is there?
Yeah, DNB is equally good. Equally good. There are many institutions in DNB. They are equally good. But only thing is, there should be, what I mean to say is, whichever the college they take, they get the equal exposure, either in government or private.
Got it. Plus or minus 5%, they get good experience. After that, where they continue their experience?
Where they continue.
Where you study. After that,
how you go back, and 3 years, it is almost like now we are able to coming to the treatment aspect. Even now, if you ask me, I read 2 hours a day. because to get updated with the tracer and the molecules treatment, all these things, because we will be treating the oncology patients, and we are here in the center of excellence. We want to do everything, everything very nicely and well in a nice way. Therefore, we should be updated. Therefore, definitely it requires.
So it's not like finish
not
the
like
PG and
no, it is
but
not
keep reading.
Keep reading with the new tracers. Keep keep doing the new innovative tracer. Then only we can be going to the next thing.
Got it. So then we discussed about the colleges and who should. Who should take up nuclear medicine apart from the rank? Like what kind of personality should?
Personalities, if you ask me, nuclear medicine, first of all, practically nobody will have the experience. Before taking the nuclear medicine, if anyone is interested to take nuclear medicine, I would suggest let them come to the department wherever the nuclear medicine is there, observe 2-3 days, and if it tells, okay, this is my cup of tea, then better to proceed, because some people, they will not be interested in sitting and reporting. Actually, more than 80% will be sitting and reporting work. Okay, it will be then handling the radioactivity, reading the physics. Okay, some people are averse of physics, they'll come to medicine. Then if they are like that, we can't enjoy the subject.
So how is the work-life balance?
Work-life balance in the sense, it's good, not bad. Most of the work will be in the daytime. Okay, mostly in other centers, if you tell, they will be doing in the morning time, because FDG will be their time. But here, since our activity, we are more into FAPI, all these things, our duty hours is afternoon and the evening, and night we will be called for. It is not like nothing, night will not be called for. There are some emergency scans, some GI bleed scans, or will be admitted patient, they will something will be there, and more than like 30% is reporting, what I used to tell. Other 50-60% constitutes other thing, like managing the radioactivity, getting the tracers. Okay, because this radioactivity will decay. For morning, if I schedule the patient 6 o'clock, 4 o'clock it will be produced from cyclotron, it will be sent. And if something happens in between, if something doesn't, activity is not coming.
So the cyclotron is located somewhere else?
Cyclotron is located, usually it will be like somewhere else. One in the state, 2 in the state, like that, and they will produce. That is only for FDG. That drawback has been overcome by gallium. That since we have gallium here, we can able to prepare it here. That FDG which is to produce and come, that is the main issue even in most centers. And whenever if something doesn't come, you should handle it, manage it. Patient would have been in the fasting, they would have been traveling 4 o'clock, 5 o'clock, then you should convince the patient. All these things are there. But apart from that, work-life balance is quite manageable.
Got it. Because now a lot of youngsters are actually dying in 39, 40. So it's pretty balanced life you'll have, updated, and you'll stay in metros. So these are the advantages of nuclear medicine. That is why it is over in 2 to 3,000, I think. So then, anything else you want to tell to conclude the session for the junior doctors who are going for NEET PG counseling? Like if somebody is interested, can they just observe you for a week or 2?
Yeah, definitely. They are welcome. They can come and observe over here. And they can, if somebody can't come, they can put a mail or anything. You can add to the description.
They have my email. They can
put a mail, or they can personally put a mail to me, and they can
your
ask
email ID. I'll put in the description.
Email ID you can put it. And whatever the therapies or any diagnostic, if anything, any doubt, they can always.
See, it's a golden opportunity for all of you. So his email ID is there in the description. You just email, write a letter of interest or intent of you working in Astro Whitefield with Dr. Pratap, and then you can actually come and see for a week or 2, so that you get an idea whether to enter this field or not. That is what you are trying to tell.
Yeah, sure.
Super. So thank you. Anything else you think you should tell the juniors, or that's it? So thank you, Dr. Pratap.
Thank you.
So my radiation, we have to measure now. I think we have to check.
No, it's within normal limit.
Within normal. Oh, super.
You are not exposed.
I'm not exposed. It is 0. Thank you very much. Thank you for coming into the channel, and we'll do a follow-up video after some days with a question and answer session. Thank you.
Nice meeting you.